Coming out to this community seminar for Dr. Bryce today. Dr. Bryce is native to Arizona, ASU undergrad, University of Arizona Medical School, residency, Hershey, Penn State, and he is fellowship trained in sports and total joint arthroplasty from Insall Scott Kelly in Manhattan. So I'd like to take a minute to introduce Dr. Chris Bryce.
All right, thank you, Ray, and thank you all for braving the rain and coming out. There may be a few more trickle in who understand there's some traffic out there as well. So I hope that this is, I want to try to make this informal. If anybody has questions as I go along here, please feel free to ask. If you have questions, I find that most other people have a lot of other people have the same questions. So, Ray, just a little bit about me to begin. Ray covered most of this here. I've been very blessed to have some great opportunity as far as my education goes. As Ray said, I'm a native to Arizona, a sixth-generation Arizonan, so our family's been here for generations. Many of you may have heard of Bryce Canyon. So that was southern Utah. That was named after my third great grandfather, and then he came and settled down in southern Arizona, and so that's where the Bryces have been since then. I want to just give a little bit of credit here to some of my mentors before we start. So throughout my training, it's about 15 years of training after undergraduate. At the sort of the pinnacle of my training, I had the great opportunity to spend a year in New York City. And I spent a year there at one of the top knee replacement center in the world. The place is called Insall Scott Kelly Institute. And here, Dr. Insall is really regarded throughout the world as the father of modern knee replacement surgery. About 30 to 40 years ago, him and his engineer really designed the modern total knee replacement that most people are using throughout the world. And it's Zimmer, the company Zimmer, is the ones that have started with him and continue to have the most true path to his design. So, Insall is just so when I was able to spend every day with both Dr. Scott and Dr. Scuderi. Dr. Scott was a team doctor for the New York Knicks for about 30 years. And just had a tremendous opportunity and learned a lot from him. And then Dr. Scuderi, if you type in knee replacement, do any research on that, many of the books are written by Dr. Scuderi. So I remember when I first showed up there, there's 4 of us fellows a year. I showed up and just fresh out of residency, thinking we know a lot. And they sat us down and said, look, we know you think you know how to do a knee replacement, but you don't know anything really. And so they said, we're going to teach you the Insall way to do a knee replacement, and they did. And so I just felt very blessed for that opportunity, and really feel the obligation to come and share that here in Arizona. So what are we going to talk about tonight? I want to talk just briefly about some of the things that may cause knee pain. We're going to talk quite a bit about arthritis, which is one of the main, most common causes of knee pain. And then we're going to really get into the treatment for arthritis. We'll talk conservative and surgical treatment. So I'm going to come up so first let's talk a little bit about anatomy. So I think in order to understand why knees hurt, you have to really understand the anatomy. And this is I'm going to kind of talk to you as I would speak to a patient if you were in my clinic, as a patient. And so let's get some anatomy straight. So this is the model of the knee. And if we open up the knee, there's two types of cartilage in the knee. So the first type is this shiny, smooth stuff that covers the ends of the bone. And this is called the articular cartilage. So if you had a turkey leg, say for dinner, and you open it up and see the white, shiny, smooth stuff on the end, that's the same stuff. If you took your fork and you scratched that, that's arthritis. Okay, so the more of that stuff that gets scratched, the more arthritis that you have. So you never think of a turkey leg again after tonight. Think about eating a turkey leg again after tonight. So the other type of cartilage in the meniscus or in the knee is the meniscus. When people say I tore my meniscus or I tore my cartilage, that's what they're talking about. So that's where we're going to start. So again, these two pictures up here. Healthy knee on your left and arthritic knee on the right, where you see some worn out cartilage there. Couple other things to notice from this slide is, so you see the worn out cartilage, but you can also see some growth around the ends of the joint. Those are called osteophytes. And so what happens is when we have arthritis is that it's an injury to the cartilage. And the body tries to heal that, and it increases blood supply. There's a lot of inflammation, and you form new bone there. And so we see big osteophytes or bone spurs on the sides of the joint. And those can cause pain as they rub back and forth across the tissues as well. So when we have arthritis, what are some of the symptoms? And these are some of the symptoms that you may relate with. You can have chronic pain, stiffness, swelling in the joint. As your arthritis progresses, oftentimes you have difficulty sleeping at night. You can have locking or catching. So what contributes to this arthritis? There's really multiple factors that go into this, and it's probably not just one thing. Certainly normal wear and tear, previous injuries can cause arthritis. Age certainly has something to do with it. Weight is one of the greatest risk factors for arthritis. Anybody who is obese has increased wear and tear on the joint and increased risk for wearing out of the cartilage. And I talked about repeated joint injuries. And again, it's usually not one thing that causes the problem. It's usually multiple factors that go into this. Arthritis, if you think you're the only one that has arthritis, you're not alone. Arthritis is the most common cause of disability within the United States. I wish I had the slide here, but out of all the joints, the knee is the most common joint affected by arthritis by far. Different types of arthritis. The most common, really the one I'm talking about mostly is osteoarthritis. That's the normal wear and tear of the joint. The second most common is rheumatoid arthritis, and that is far less common. Rheumatoid arthritis really affects many joints throughout the body. Interesting, women are actually at greater risk than men for arthritis. And we think it's just something with the structure of the mechanics of how they knee replacement is a very common surgery. 600,000 knee replacements are performed every year in the United States. So I often get asked in clinic whether if a patient has a knee replacement, if they'll sound the alarm in the airport. And I say, well, yeah. And they say, well, can I get the card? And we haven't given those out really since 9/11. They'll just tell you to put the card away, and that you just have to tell them that, yeah, it's you and the other million people, or I guess 600,000 people in the United States are going to set off the alarms as well. So it usually puts their minds at ease. So let's get into a few of the options for for treatment of arthritis and knee pain. So we're going to start very conservative, then we'll go up into surgical options. Anybody who is overweight, the most important thing is to work on weight loss. Every step you take is just normal walking is about 5 times body weight through the knee. This has been shown over and over again in mechanical studies. That's just normal walking. Anything like climbing stairs, even getting out of a chair, any type of hiking can be as high as 10 times body weight. So I tell people, look, if you take off just 20 pounds, that's not 20 pounds through the knee. That's really minimum of 100 pounds with every single step that you're taking. So weight loss is a huge factor in relieving knee pain. Exercise, let's talk about that just for a little bit. So you really should be doing a low impact type of conditioning. So generally the number one choice would be a stationary bicycle. Things like an elliptical would be a close second. Anything in the pool is good as well. Things to avoid, you really shouldn't be doing any running, jogging. Should stay off the treadmill if you're having knee pain. The biggest thing is just to avoid high impact conditioning. Even going out and walking long distances for exercise, we consider high impact. I'd much rather have you, if you're going to spend a half hour to an hour exercise, I'd much rather have you spend that time on the bike. Now, does that mean you can't go out and walk? No, it doesn't mean you can't go out and walk. You need to do those type of things to clear your head. It's good for your head, it's good for your heart, but not so good for the knee. Other things that can be effective, hot and cold compresses. Generally, heat is good before you go out and exercise. Cold is good after you're done with exercise. And then we often try physical therapy. The biggest thing with physical therapy and any type of exercise is to work on strengthening the thigh muscles. The quad and hamstring muscles really help to stabilize the knee joint and take stress off of the knee. So those are the big things. Other things that have been tried in the past, shoe inserts, those are plus or minus. Sometimes we'll try to put a wedge in a shoe that unloads one part of the knee. Not a lot of good data. I haven't had really good results with that. Sometimes we'll try bracing. Bracing generally sort of makes you feel safer with your knee, like you're able to control your knee better. And then walkers, canes, we use often if we're just trying to avoid a surgery. And then joint injections. We're going to talk a little bit more about that later. Really 2 types of injections. Most common type is the steroid injection. Those we generally do every 3 or 4 months if needed. And then a lot of you have probably heard of the rooster comb injection. Zimmer has one that I've started using more recently called Gel 1. It's one of the newer formulations on the market where it's much more concentrated, and we think that it's going to stay in the joint longer than some of the others that are out there. Yeah, anti-inflammatories, that's an important one. Ibuprofen or Aleve are really the mainstays of the ones that I use. But we can't have you on those for a long time. They can be hard on the kidneys, they can be hard on the stomach. But for temporary relief, we use those. We use these very commonly. Disease modifiers, those are really for rheumatoid, inflammatory type of arthritis. So once we get past non-operative treatment, so when do we know we're past non-operative treatment? When do we consider surgery? Well, it's really when we've tried all of these other options. We've tried rest, we've tried strengthening, tried weight loss. Anti-inflammatories injections just have become less effective, and so then it's time to start considering surgery. One of the other big ones is if the pain is keeping you awake at night, and you're just not able to do what you want to do. So what are the options? What are the surgical options? Arthroscopy Arthroscopy for straight, I get this question a lot in clinic. Well, can't you just go in and clean up the knee, stick the scope in and go in and clean up the knee, and then I'm good to go? Well, remember, if you think back to the first slide there on the anatomy, arthritis is really caused by wearing away of that cartilage. So once that cartilage is gone, it's gone. There's no building it back. And so to go in and clean up more cartilage, we found that we can give you some temporary relief, but I really don't feel like I give you much more relief than I. Let me talk just a little bit more about total knee replacements. With a total knee replacement, the things that you can and can't do. So with a total knee replacement, they're designed these days to keep you very active. A person who plays tennis could play doubles tennis. A patient who skis can ski. I wish I had the video. In fact, 2 weeks ago, one of my patients, who's an 82-year-old grandmother, sent me she's been an avid skier her whole life, and 2 weeks ago she sent me a video of her skiing with her granddaughter. Things that you can't do with knee replacement: you can't run, you can't jog, you can't do high-impact type of activities with knee replacement. There are some risks for knee replacement, and we take very strong precautions to prevent these risks. Some of them are listed here. Infection. The national rate of infection with knee replacements is about 1 to 2% throughout the nation. We do lots of things to prevent that. Usually you get IV antibiotics after the procedure. We wash the knee out with a very strong antibiotic solution before we close it up. Generally, for the rest of your life after you have a knee replacement, you have to have antibiotics whenever you have dental work. The dentists know about it. You just tell them you've had a knee replacement, they know what to do. Blood clots, I put my patients on 2 weeks of a blood thinner after knee replacement to prevent that. Risk of bleeding, and then a need for additional surgery. So that 90% at 20 years, that's very good, but that's not 100%. A fraction of these can wear out, loosen. If any of that were to happen, you may need to have additional surgery. When I was training back at the Insall Institute, we saw things have just progressed so much. So I watched a couple of videos of Dr. Insall doing his knee replacements 30 years ago, and how they would align the knee is there were tiles on the wall. All the walls were lined with tiles, and they would stand back and they had a level going across the knee, and they would align it with the tile. And that's how they told if the knee was, that's how they could tell if the knee was going in straight or not. And so we're a little better than that now. So, used to be the incisions were very long. These days with the newer instruments that we have, we're able to get the incisions down. Most of my incisions are about 10 to 14 centimeters. I often have patients coming in and say, well, how long is my incision going to be? And I tell them, well, it's going to be as short as we possibly can, but long enough to get the knee in safely. And so, again, I do a fair amount of revision work, and I see these little tiny incisions, and a lot of times it's no wonder that the knee didn't get in properly. So, one of the things So I mentioned that I do a lot of revision type of work, of redoing knee replacements. Whenever we have to redo a knee replacement, one of the risks is that you lose bone. When you take out the knee replacements, you lose bone. And Zimmer has something that's called trabecular metal. That's a picture of it's a metal, and it's actually very porous. But the bone, we're able to put that into those voids of bone, and the bone grows right into it. And this has become a very good solution for some of these complex revisions where we're losing a lot of bone. You'll see if you go on the bus afterwards, you'll see there's a little water fountain with a little cup, that has water going into the cup, and you can see that the water is just coming right out the other side of that. So it's a very unique technology that they have, and I use this on a lot of my revision knee replacements. Okay, yeah, so I want to spend just a little bit of time on this. So I mentioned that I trained at the Insall Institute, where really the modern knee replacement was designed. He's the father of modern knee replacement. And so about every probably 10 to 15 years, a new generation of knee comes out. We just got the third generation of knee replacement. It's been about 10 to 15 years. And the second generation, which is the one I was trained on when I was in New York City, had been at the top of all the world registries for about the last 10 years. And now we have the Persona. It's called the Persona knee system. And this is based on the one that was already very successful, but we think this is going to be better. Some of the reasons why, at least long term, and I will tell you, just in the last year and a half to 2 years since I've been using it, patients just seem to do well with this. The reason, one of the reasons why I think that is because I have so many more options as far as sizes within the operating room that I'm able to really dial in balance in the knee and just get things just perfect. So I mentioned this plastic. Up until I had the Persona, we had 2 millimeter increments to be able to balance the knee. Now we have it down to 1 millimeter increments, and so we're able to just dial these things in just pretty precisely these days. This is also designed, another improvement in the design over the last one, which again was very successful, is we take much less bone. The engineers were able to design the knee replacement so we cut out less bone. It's a very bone preserving, and so if at some point it does need to be revised, we don't run into as many problems with bone loss.